Rob and I are great pals. We go back a long way. We're writing a book together on denture making. We're two denture fanatics. I don't know if that's good or bad. I'm a prosthodontist in Albuquerque. I've been practicing 43 years. I've been making digital dentures in some form since about 2010. But right now, I'll tell you, they've really turned the corner. And what we're going to teach you today is really the foundation of all of it. We're going to show you how to do a reference denture technique, a modified traditional technique, which is an impression, pretty much like you did in dental school, but we're going to end up with a digital file. We're going to show you how to scan intraorally, telling you about the advantages and disadvantages of that technique. And then we're going to talk about immediate dentures, which is really kind of the gateway of getting into digital dentistry. These techniques are all practical, something you can take to your office immediately. And with that, I mean, it's really something that I think you need to look at. This is a denture that I put in here just to remind me that just to implore you to really look at making digital dentures. You've got to do it. If you're not doing it now, you're missing out. It's changed everything in my practice. I'm now making all my dentures digitally. Every one of my final dentures, and I make a lot of them, are digital, all the way from Medicaid patients here in New Mexico. That's the state-funded dentures, all the way up to my more sophisticated implant-based dentures. So you've got to do it. And there's a lot of reasons for it. I mean, from a clinician, time is a big thing. The old technique that we learned in dental school took 5+ appointments to make, at least 5. And, you know, at $5 to $7 a minute to run that practice, that's a lot of time spent. And especially if you have limited amounts of insurance funding in your area, there's a ceiling there. Really, the amount of time and the amount of money you could make from them don't jive. And so it's a problem. But now with digital, we can do dentures routinely in 3 appointments, sometimes 3 30-minute appointments, and it makes a difference. And this is the big one for me, and I swear it's true. I don't even appoint adjustment appointments anymore. I give the dentures to the patients. They smile. We adjust them a little bit, maybe adjust the occlusion. Off they go, and I say, give me a call if you need any adjustments. They don't call. Every once in a while, a few, but we're almost down to 0 appointments, which is extremely significant. Fit is that's really the secret. These things fit because these digital impressions are so accurate. If you look at this image here created by Brian Goodacre, the image on the left that has the pack and press shows the amount of accuracy that the pack and press technique provides. Any place in green is an exact fit to the edentulous arch. Anything in white or dark or light green means it's not fitting that well. If retention is caused by the intimate fit of the denture to the gingiva, you don't have a lot of intimate fit here. But if you look over on CAD/CAM, and I'm talking about printing, I'm talking about milling, any CAD/CAM dentures, they're almost 80 to 90% precise, which makes a big difference. They fit better, they stay in better, and there's less adjustments to be made because they fit so well. So fit is a big one. Strength is a huge one. One of the big complaints that we have on analog dentures is tooth pop-outs or denture breakage. CAD/CAM dentures can be up to 2 times. Isn't that true, Robert?
Absolutely.
They can be up to 2 times as strong. Here's an example. If you took an analog denture and do what this guy's going to do to them, it would break in a second. That's a concrete floor.
This is the Kaiser test.
This is the Kaiser test. That's a digital denture that has been printed. Teeth don't pop out. Dentures don't break. It makes a big difference, especially over, let's say, 2 implant overdentures, something like that. It makes a huge difference.
And look at it, look at when Jerry drops it down and bounce. Most,
I think the record is somebody threw it out of a 5-story window onto a cement next to a pool at a Holiday Inn, but it did pretty well. Now, what do you need to do to start this? Basically, what the armamentarium is a scanner, in this case, a Medit scanner. This is one that's promoted and sold by Microdental. So you need a scanner, an intraoral scanner, and you need a patient. That's it. We're going to show you how to use those two tools, use a patient and use the Medit scanner, and we're going to show them how to make these impressions. But first, I'd like Rob to kind of tell you what does make a good impression.
oh, thank you, Steve. Appreciate it. So what I look for in an impression, you know, and this is the environment they're working in, trying to think about capturing this, you know, soft tissue anatomy, you know, functionally or, you know, and statically. This, you know, we have to capture all these anatomical landmarks. So, you know, there's different techniques, you know, like Steve's going to show you, whether it be, you know, utilizing an iOS system or scanning an impression or even scanning models. But the best is scanning, I believe, an impression. The showing just some of this soft tissue anatomy, I think, is really important. And, you know, Steve, you know, comment on this year clinical experience, how difficult this is to capture these labial frenums and buccal frenums, you know, and right. The this sublingual extension, you know, and as well as around in the labial of the mandibular, the mentalis muscle. You go back and you see this real prominent, you know, buccal frenum, you know, that's you have to relieve the denture for. And then also on the upper right, showing the retromolar pad in relationship to the tongue. And thinking you have to get the wand all the way back. So when we analyze digital scans, and we're seeing, you know, an increase of at least 30% of scans being sent to us, and we're every day getting more and more scans, whether we do complete dentures, partial dentures, for flexibles or for cast frameworks or orthotics. You know, we're seeing a huge increase in the number of scans we analyze every day. But one of the big things we see is missing in the retromolar pad area and the lateral throat form, and which is really, really difficult, I think, to capture with the iOS. This is, you know, was up there, you know, that was image from Dr. Preskel back in 1968, you know, showing, you know, a real good image of this functional soft tissue. But looking at the maxillary dentulus, you know, arches, these are all the different, you know, when I analyze something, what I have to look for, the different checkpoints. You know, first of all, look at the peripheral border extension. Is that do we capture horizontally and vertically the proper extension? And look at the functional anatomy, this frenum attachments and the hamular notches. Does it all the way go back to the distal of the hamular of their tuberosity and capture that hamular notch, which a lot of is missing data on a lot of scans. And then the area of support, hard palate, tuberosities, anterior rugae. Did this all capture without any holes in the scan? Incisive papilla, very, very, you know, important to capture this. Or actually, you know, if you can have, you know, sometimes incisive papilla is compressed after wearing a denture for a long time, and either have the patient take the denture out for a period of time or put in a tissue conditioner to revitalize that soft tissue, and especially that papilla area, I think is really important.
But one thing, when I see a picture like this, Rob, I think about the, you're really capturing a dynamic situation. You've got tissues that move, and you want to place them in an area that would be properly opposing a denture. In other words, you don't want to make an impression that spreads everything out, because that would tighten the tissues. And you don't want to have something that just covers just barely the minimal of hard tissues, because they won't be retentive. So the trick with a denture, just like a denture impression, just like it has always been, is you want to be able to really mold the tissues as you make that impression. You can still do that digitally, but I think this picture really illustrates there's so many different things you have to capture.
Yeah, absolutely, Steve. You're at 100%. And then, as I was saying, into the throat form, and really, getting that entire, hem or notch area, so you can, visually tell if it's a class 1, 2, 3, throat form. And then looking at, so we'll get the scans in. And so this is a scan that received inside the existing denture, or you can do this as well as a duplicate denture, but recapturing, reestablishing all the peripheral borders, making sure we have good borders. You can see on looking from the posterior view on the patient's left tuberosity, how it really extends around the distal of the tuberosity, which is really important, also aids in retention, which that one area we see always missing data with the iOS, which becomes more difficult. So we always look right away at these peripheral borders, and whereas this dentist, you can see, actually prosthodontist, captured this, functionally with border molding and reestablishing the peripheral borders. Again, on the mandibular, looking at, these are all check marks as you do the scan or do your impression that you plan on scanning with your iOS, is to just, think in your mind, I have this area, yes, I'm capturing the retromolar pad, the lateral throat form, the sublingual extension, the mylohyoid, the retromylohyoid, all this, the buccal shelf, alveolar ridge, and look at the bone height, and capture all these frenum attachments as you're going around, thinking about all the soft tissue anatomy, and then double checking it, before you send the file out, make sure it all has been captured, whether it be through an iOS or scanning your impression with the iOS. Again, looking from the intaglio surface of the maxillary mandibular dentures, there again, we look at, the peripheral borders, look at the soft tissue anatomy, the incised papilla on the maxillary intaglio, you can see the anterior rugae. You see a little bit of areas that in the mid palate on the left ridge, and we see this sometimes in scans where I don't know if that's an area where maybe the saliva, there's a little bit of saliva, maybe a little bit of denture adhesive that didn't get cleaned out. But it's interesting in looking at scans where you can blow them up, you see so much more detail than we would normally see with conventional impressions. And then from a sagittal view, looking at the dentures, I always ask if in this case we're going to increase the VDO. I always ask the dentist, when you take your bite scan, take a check bite with your desired increased vertical dimension, rather than asking us to open it up in the software. Firmly believe it's really important to get that established VDO in your bite scan. And also looking from the occlusal view, we can analyze the dentures and the teeth, the anatomy. You can see it's interesting on the mandibular scan, the denture teeth are worn much more than the maxillary. I don't know if maybe the denture was made, it's an older mandibular denture and a newer maxillary, but much more significant wear on the mandibular. And also we can see where the teeth are slightly buckled to the ridge crest on the patient's left side as compared to the right side. So this would be things that we would look at and address. And as Steve's going to talk about in a reference denture, how we could change this occlusion or tooth position to increase stabilization. Throat form, as we said, is very, very important and, functional. And, we talk about whether the patient has a class 1, 2, or 3 throat form, and how do we extend the posterior palatal border, depending upon these classifications, as well as thinking about the posterior palatal seal. So conventionally, when you conventionally processing, we would go with deeper post-dam, posterior palatal seal, in a injection molding, we would do slightly less, maybe go half to 1 millimeter. But when I'm finding out with digital, when we're doing a printed base or a milled base, that I don't believe personally it's necessary to do a deep posterior palatal seal. I think the ideal is to do a physiological post-im in the impression with border molding compound and then scanning that in. But Steve,
Right.
a comment on this?
Well, I think the argument is do you need a post-palatal seal at all?
Correct.
And there's some very prominent dentists that say you don't. I think you do, because the idea that the soft tissues are going to stay stable over time is incorrect. The denture is going to stay one shape. The soft tissues are going to change year to year. So I think you still need to put a post-palatal seal in. I like a little bead and just across in the soft palate. But I think this is one of the points that we don't know. Everything's so new, but people are finding that you put a denture in, it just seems to be retentive just because it fits so intimately to the tissues. I think it's a question that we don't know the answer to at this point.
Absolutely. Correct.
Sorry about that, Rob. I didn't mean to change your slide. We're gonna be presenting an overview of these 4 techniques. We just have a few minutes. So what I'm gonna suggest is, if you want to start doing this kind of work, I want you to contact me one-on-one. I'll explain, and I've got slides that I can show you. Maybe we could do a personal Zoom or something like that, and I'll explain step by step what you need to do for your first case. So take down my email. It's bigjawbone@mac.com. I've got bunches of people calling me over time, and I'm always glad to help. I'm just so enthused about what we're doing, but I do think you need to sort of have a hand to hold when you start to do some of these techniques. So let's explain them. The one that I think is probably the most important that you do is a technique called a reference denture. This is an easy one to do. It can be done on almost 70 to 80% of people that walk into your office that are edentulous, because 70 to 80% of those patients are going to have dentures that you could use as a start. I'm not going to walk through the details of the whole process. We're going to concentrate on impression making. But this is the thing that I think you should really give me a call about first. What you need to do is have a patient that comes in with a denture. And this is a denture I made maybe 2005. The extensions are reasonable. The patient was happy with the aesthetics. It's seen better days. I made it out of a clips, which is a urethane, a light cure urethane. But the patient's vertical dimension is slightly closed. The denture is worn out. The key is that the patient comes in saying their dentures are worn out, not that they hate their dentures. If the patient comes in and said, I've got a set of dentures I just cannot stand, this is not the denture to use for a reference technique. You need to have one that they're fairly comfortable with. Here's a patient who's been a long time denture wearer since her 20s. She's got a denture that's not aesthetic, but she tolerates it. She's very amenable to wearing a denture, but the thing is worn out. So what I can do now is take that denture, rather than trying to reinvent the wheel, I can actually use that denture to help me develop aesthetics, the vertical dimension of occlusion, phonetics, everything that would go into a new denture, but I'm not starting at point 0. I'm starting at appointment 1, and I'm going to be able to deliver a denture to her appointment 3. So here's how we do it. The first thing you do is look at that denture and see if it has extensions that will be amenable to a well-formed denture impression. In this case, the heels weren't covered in the mandibular denture. So I extended it with some resin, some compound, whatever materials you would have, so it covers the pear-shaped pad. So you just take that denture, look at it, modify it quickly so it's not short, something that you would feel would produce a a well-formed denture once you made your impression. Now, I like to use polyvinyl siloxane impressions, and the reason why I like them is that it's easy to use. It comes in different viscosities, as you see here. The green is fairly thick. I use that for border molding. The middle one I use for my impression making, and the yellow one I use for maybe correcting the impression if I need it. But these are the three viscosities that I use. And I specifically use a material called Aquasil Ultra Plus Fast Set. The secret there is fast set. It sets in 2.5 minutes rather than 4 or 5 minutes, because I'd like this process of making an impression to go pretty rapidly. You need to paint your denture with adhesive. Several people say you don't need adhesive for the process. I think you do. It makes it a lot easier to scan. So you paint the denture with adhesive, and then I'm going to border mold that denture with Aquasil Ultra Plus Rigid. It's a fairly thick viscosity material. And here's how I do it. Paint the denture, paint it not only on the intaglio surface, but on the cameo surface, the outside surface as well. And then you start applying your material until you go all the way around the periphery, and then put a little bit in the middle to boot. You place it in the mouth, hold it in the mouth for 2.5 minutes. During that time, you have them go through border molding motions, just like you would be doing with a traditional impression in an impression tray. You could also have them hold it in with the opposing denture, but I found that that doesn't work quite as well. Have you had any experience with that, Rob? Sometimes it seems like the occlusion of the denture just makes it shift. What do you think?
No, I agree with you exactly. So it's I mean, we've had really good results with, instead of holding, if you hold it down, if they have an existing denture, have them occlude against that denture as well. It's really, up to the clinician, I find, but I agree.
Right. You let us sit in this. Actually, this material could take it in a minute, to be honest with you. It's 90% set, but 2.5 minutes full set. So anyway, you leave it in there, and this is what you end up with. And now we're actually starting to see what appears to be what a classically shaped mandibular denture. Now, the one thing that you'll notice is that we have show-throughs. You can see the denture through the green material. We want that. If you don't see any show-throughs, that means that you probably didn't position your denture correctly. Just like you were doing a reline. If you do a reline where you get the denture, let's say in the maxilla, not all the way up, you end up with a reline that's sort of down and forward, which patients hate, of course. But with this, look for those show-throughs. Now, do not touch those show-throughs with a burr to correct them. The one secret that I've learned is you don't touch a denture you haven't made. Ideally, we would relieve those, but let's say the patient goes south on you, gets mad at you. You've touched their old denture, and I've had this happen to me. And maybe I made a little minor adjustment on it, and the patient says, lifts it up with their tongue and said, well, now it doesn't fit. What are you going to do, doc? Well, I've ended up remaking dentures for them. So the idea here is that we're going to have show-throughs that are not ideal, but to me, this is a good start. Then I do a wash in Aquasil Ultra Plus LV, light viscosity. Again, a 2.5 minute set. And after 2.5 minutes, this is my final impression, which I think looks pretty nice. You still see those show-throughs, but this is something that Rob could use because it has full extensions onto the pad. It has nice rounded flanges, which will make the seal more secure. This is a good impression, and you've done it really in about 5 minutes in the patient's denture. Now, you're going to do the maxilla in this case and the mandible, and because we're going to put these dentures together to take our interocclusal record, you need to remove any of this material that would interfere with the maxillary denture occluding against the mandibular denture. So you take that cut it away with a barred Parker and free it up and make it, just make it so that the maxillary denture will be able to occlude into this without any interferences. Then I take a interocclusal record with, in this case, Regiseal. You could use Blue Moose, any of the polyvinyl siloxane materials that are on the market. But the idea here is that you're going to take a very generous interocclusal record, and you're going to then put them together at your scanner, and we're now going to scan all this together. So now we've made our impressions, we've taken the bite, we're probably 15 minutes into the appointment. I then leave the room and I have my assistant scan these dentures, and I'm going to show you how that works. Basically, what you're going to do is take the denture and scan the occlusion, go to the buccal and labial surface, scan that, connecting everything together, just like you would do with a scan intraorally, trying to cover the entire cameo surface of the denture. The palate's kind of hard to scan, and sometimes you can't get the middle of it, but most of the time you can. Then you take your scanner and just swing over from the flange and scan the intaglio surface of the denture. And that means all the way around. There are a lot of techniques that show you follow certain patterns, but I found you just sort of do it. Once you get it done, you've now scanned both the maxillary denture, the cameo surface and the intaglio surface. We call it a 360 scan, and you've ended up with something that you could then work with. You do the same thing on the mandible, 360, scan both those together. Then you put the dentures together with the interocclusal record and do what you would do intraorally, extraorally, and do a buccal scan, both right and left. In other words, you've then mated the maxillary scan, mandibular scan into something that you can send to microdental, and they can produce something like this. This is a monolithic try-in. It's either milled or printed using the teeth that you've selected or the teeth that are on the denture, any modifications that you suggested. And this is something that you then try in appointment 2. I don't know if any of you attended my last talk, but we talked about this technique. I'm doing this all the time. First appointments under 30 minutes. My try-in, since these fit just like a final denture, my try-in is minimal. I can make modifications, suggestions, and write notes, take photos, get information to Rob and his crew. But this is what you would put in their mouth appointment 2.
And on that, it's really important to get the point, if when they try it in, to always take a check bite to reevaluate, so we can scan in and verify that bite scan. And just same way we do check a remount on an articulator.
Now, the other thing is, let's say we want to do some modification on the labial flange. You know, a lot of times you want to shorten a flange. Well, if you do that, you'll rescan this monolithic denture and send that information. Any changes you make to this will be mirrored in the final product, which means that when you give them the final denture, you don't have to touch a burr to it because you've already done it. And that gives a lot of security to the patient. They really feel like they've got something that, you know, it doesn't need to be touched to fit. I put one in about an hour ago, fit just great. And now here's an example of a printed denture out of microdental. And I don't think I've seen a better denture in my life. This thing's beautiful. This is really a beautiful, beautiful denture.
Yeah, thank you.
So that's
it's amazing how far with the digital dentures. Yeah.
I mean, and you take this appointment 3, it just fits in, no problems. Just you put it in, it minimal adjustment to the occlusion, minimal, if any, adjustment to the tissue surface. And I guarantee you these patients will not be coming back for adjustment after adjustment. They fit that well. So that's the reference denture. Again, call me when you want to do it because I have a lot more slides that'll show you specifics. Now, what if they come in with a denture that isn't a good one to start with? An example would be they just had a denture made with Dr. X down the line. They put in too small teeth. The patient hates it. They're over to you. Well, you don't use that for denture because you'll end up making a denture and they'll say, well, gee, it started with my denture I didn't like. I don't like the one you gave me. So this is more like the dental school technique, the technique of making an impression, going through the process. We're going to call it modified traditional because we're going to end up with a digital scan also. Now, this is what I use in my office. These are impression trays that I developed back in the early 2000s, and they eliminate the need to make a preliminary impression, a laboratory fabricated custom tray, and a second appointment. In other words, we're going to cut a whole appointment out. And these are trays that you can mold, shape at chairside. Microdental has them. If you have any interest in them, you can contact Microdental and they can show you where you can order them. But this is what I'm going to demonstrate here. The armamentarium for this are the trays themselves, a source of 160-degree water, which in this case is a tea kettle. These are $70 off of Amazon. A timer, because we're going to time the amount of time we have the tray in water to soften it, and some scissors to change it. So this is the workflow here. This is chair side. You take your 160-degree water, pour it into the tray, leaving the handle exposed, and it will soften just like well-tempered compound. It becomes flexible, but it doesn't sag or drag. Well, you use 160-degree water for a minute. You can then take that softened tray, place it in the patient's mouth, and go through border molding motions. Pull the lips down with your hands, have the patient move their mouth. Whatever you learn in dental school to shape a final impression, you're going to do it with this tray. We're going to then paint the tray, apply one of the materials, just like we did with the reference denture. We're going to take rigid, put it in the tray. Now I'm applying it around the periphery, just like I would with my reference denture technique. And I'm going to apply some material in the middle, and I'll show you why. You take that and then go back to the mouth. You've already shaped the tray so it fits like a custom tray, and go through border molding motions. And you can leave it in a minute if you want, 2.5 minutes for full set. You take it out and you're now starting to see the shape of your final impression. If you look at the thing, you'll see that there's some show-throughs, meaning that the tray is pushing up against the tissue, displacing that tissue. You don't want that. We want to make this a traditional dental school impression, and we're going to relieve any of these areas that that could be pushing on the tissue. We don't want it to do so. So here we're grinding on it. Here's an example. If you look at this, you can see the maxillary mandibular impression, and you can see where the tray is overextended, especially on the labial of the mandibular tray. You can see that I'm overextended there. Well, take your burr and just grind on this. Again, this is chair side and it goes real fast. We'll use LV, and we're going to do the same thing. We're going to apply LV to the tray. Put that in the mouth, go through border molding motions, and in 2.5 minutes, you have your impression finished. It's ready to go. If you see any little bubbles or areas that you didn't do a good job with, you can apply XLV, which is almost like water. And 2.5 minutes later, you have another impression. So to me, this looks like a real nice impression. I was pleased with it. And I think this is something that Rob would be glad to get in a scanned form.
Absolutely.
So You make a maxillary impression, mandibular impression. Now we're going to scan these impressions chairside. Just like we did with the denture, my dental assistant is now going to just take that intraoral scanner, go down and all the, take 3 minutes to capture one of these. And you can see that she's just working around trying to get all the details that Rob would want to have in the final impression. Now, what we do with this is we would scan the maxilla, mandible, send it to Rob. He'll make either a base plate for you, or he has, if you do some other techniques, he can actually give you another monolithic denture. And then following that, he can end up with his final denture as well. So those are really the two techniques that I use in my practice. Reference, I'm doing probably 70% of the time. The impression with my trays, I do 30% of the time. Now, I'm going to show you intraoral scanning directly. And there's a lot of appeal to that, but I think both Rob and I feel that its time has not come yet. It's difficult to get a consistent result. And for me, it's much more, I'm much more satisfied by making a traditional impression and scanning it rather than scanning in the mouth. Because you got to realize that when you scan in the, when you make an impression, you're not only copying the gingiva, you're displacing tissues too. And you don't do that with an intraoral scan. Now, someday this might be the way to go. And there are proponents out using it day to day, but most of the people that I know have tried it aren't using it yet. So intraoral scanning. The secret here is that you need to have a maxillary ridge or mandibular ridge that is mostly made of attached gingiva. If it's flexible tissues, you will not be able to record it with a scan. A scan has to work off of rigid bodies. But the technique is pretty direct, almost like you were scanning a denture base. You start at one edge, scan around, keeping the tip of the scanner about 5 to 10 millimeters off the ridge itself. This is really a two-person job, one person extending the lips, the other one scanning. Now, if you look at this, it's almost hard to read. There's a ridge in there someplace, but this just demonstrates that if you get down here, you've got tissues that are going to move. They just can't help it. And any tissues that move, you're not going to be able to capture. But this is an example of one that did really pretty well. This is from Brian Goodacre down in Loma Linda, a young prosthodontist there. They found that they can scan the maxillary ridge pretty well. I don't find my scans to be consistent, but they do pretty well on the top, and it takes them about, let's say 2 or 3 minutes to get a successful scan if it goes well. And this is a successful scan. The mandibular scan is the tough one. This scan took him 40 minutes to make. And it was after a lot of trial. I mean, for me, we've had the patient out 20 minutes earlier with our traditional techniques. But, you know, I'm mentioning this just because I think it's something that so many people want to do. So many people want to avoid impression making at all. But I think for us now, we should really think that this is a technique that's time will come. Would you agree with that, Rob?
Absolutely. You know, we have to look at, what is the best, what do we get the best results with? And also think about chair time. Like you said, if it's extensive chair time, you could capture that impression in 10 minutes and then scan that in a couple minutes. So no, I absolutely agree. It will come and it's there. It is there for immediates right now. Immediate, it's very simple to do that. An immediate denture, especially, if you have teeth that have a degree of mobility, you want to avoid extracting the teeth during impression, then by all means scan it in, and we'll go over that as well.
Well, speaking of, I mean, now this is something we use all the time. I don't make impressions for immediate dentures anymore. I 100% scan them intraorally. The reason why we do that is that the teeth are rigid bodies and they're great for the scanner to key off of. So just like the reference denture is kind of a gateway technique, the immediate denture, if you've never done any digital, do it for the next immediate denture that you have. Here's an example. The vertical dimensions closed. We have caries. We have fractured teeth. The patient needs an immediate denture. You could either make impressions. I'm going to suggest that you scan. And here's my scan. It's immediate dentures. When you have teeth in place, the scan is almost foolproof. It goes real well with the modern scanners that we have now. You can scan soft tissue, can't scan movable tissue, but you really don't have to worry about it too much with the immediate denture. So here's the upper takes a maybe minute to two to scan that. Mandibular scan, this is going to be an opposing model in this case, but this is a fairly easy scan to accomplish. Just like you were doing like a crown prep, really, just a full a crown prep scan. Now, what we do is we then determine the vertical dimension of occlusion increase using a leaf gauge. And there's several of these on the market for you. But you're going to actually put this in the mouth, determine the vertical dimension of occlusion by adding or subtracting pieces of the leaf gauge until you're happy with it. And then you're going to go in and do a buccal scan, both right and left, to create this kind of arrangement. Rob can take this, your maxillary scan and your mandibular scan, and actually create a combination of both, and then start to create their denture, their immediate denture for you. Excuse me. They can use the position of the teeth, notes that you've made, photos that you've made, the increased vertical dimension of occlusion. Excuse me.
And what's important also in immediate dentures to communicate to us, if there's going to be any, socket bone grafting, or how to extract the teeth virtually. It's extremely important. If we're going to do a conversion denture later on, of course, we're going to do alveoplasty, but little things like that, is important because we want to provide space, enough prosthetic space for the teeth and base. But if we don't get the proper instructions as far as any type of augmentation, then then it's going to be difficult to deliver the case.
Right. So I guess just to reiterate, this is easy to do. It's fun to do. The results are very consistent. You can really use this as the start of even sophisticated work by using your immediate denture to transfer into, let's say, implant-based dentures, more definitive dentures. But this is really the start. So I think that's our slides then, Rob.